cry, or I want some attention cry, or change my diaper cry. Okay. All right. So all of that's correct. And some of those can also be seen in other conditions where they have that loud shrill of a cry that's, very unnerving. I am looking for something specific because it's an actual position they will actually be in or display. Something like that. It is an arched back. And so the arched back is known as epithotonus. So literally it's almost like the baby is doing a back bend. So, if you're a gymnastics person and they, put their arms back and they have that kind of that cat stretch, but the opposite direction, then that would be the position that you would see the baby in. Yes. Let me show you a picture of what that would look like. Let me get it real quick, and then I'll share my screen. So if you see it, then you would know, and they're not the only ones because it's a posturing issue. So that can also be seen in adults as well. But I'm going to show you one with a baby. So that way, and I'm going to share my screen so you can see it. Me talking about it doesn't mean anything. So all right, so you should be able to see my screen. And here you would see this little baby here on the right. And look how arched the back is. This is an abnormal position for babies. Now the screen actually also shows adults and things like that, but we would know other information related to the adult. But for the kiddo, the kiddo would be kind of hard to tell. And then there's a couple of others for which would be the same thing. So here you have an older kid having the same type of position. Okay. Questions about that? So the shrill is correct, inconsolable. So all the things that you posted up in the chat, all of those are correct. Good question. So what are causes of this causes because they have a brain tumor. So this is what we're talking about right now. But now you would have to look at what are the causes of a brain tumor. So that's a very good question. So what would be causes of kiddos developing a brain tumor? Because the brain tumor is one of your exemplars, right? As the tumor progresses, this is one of these bold-like positions that they will display. So what we're talking about is what causes this, which is a brain tumor. But now I'm asking the question, what are common causes of brain tumors in pediatric patients? So that's the question that I have on the table. Now I lost there we go. I'm gonna stop sharing. There we go. Okay, genetics, head injury, okay. Any others? And there's a variety of types of brain tumors, whether you are an adult or a kiddo. So the symptoms will vary by age. But, besides this abnormal posturing exposure, yep, there we go. So all of those are possible reasons why kiddos would actually develop a brain tumor. With that in mind, as they progress through age and depending on, when this actual condition shows itself, they can have a headache that, starts in the morning and maybe goes away in the afternoon. But things like loss of balance, especially after they've learned how to walk, um, difficulty walking, handwriting gets worse. Now, children's handwriting isn't the best, but then it's wherever their level was prior, you see a decline in that. Slow speech, seizures, reduced visual acuity, because depending on where the actual tumor exists in the brain will determine some of the changes that they may have, whether it's personality changes, visual changes, sensory changes, gait changes, because those are different areas of the body that may be affected. So just kind of food for thought is, don't forget about the brain tumor folks as well. And this could be across the board, but they do have that epithetonis posturing, which is kind of common. And if you saw that in your pediatric patient, what would be the first thing to do? So how is stroking their back going to work? Okay, safety. I can go with that. If that is something you saw, wouldn't you want to seizure precautions? Okay, I like that. But looking at the first thing, so you know, we have diagnosed that the baby has, this brain tumor. They start having this arched back. What we need to do is look at calling the PCP. All the things about safety are correct, because when they have this process, the epithetonis, this is more of now the brain stem is herniating. So when the baby's back is arched as such, so yes, brain tumors do have an increase in ICP. It is right along with hydrocephalus and meningitis and all the others that we talked about prior. But when you see this particular, arched back, then we need to be, this is now the brain is herniated. So that's what that means. Now, if the symptoms were missed prior to, and probably not, because you have a baby that's crying, you can't console it, so forth and so on. Or if it's an older kiddo and all of a sudden they just have difficulty walking, then that's going to be an issue. Not sure if this would necessarily lead to decerebrate posturing, because here we already have the brain that's herniated. So I'm thinking this is their final posturing process. And I could see that transitioning there, because the corticate would be more in, and if they're arched, they're already away from the core. So that could be a potential, Tom. But stroking the back will not relieve the herniation or release the arching. So I know that someone put in there stroking the back, but if you stroke the back, it's not going to stop the arching. It's not going to stop the herniation. They need to now, do something more significant. We will side the bed. We would make sure we're going to prevent injury. But the first action, once you see anybody patient in this position, is to contact the physician. So if you put the patient like in a prone position, that's, because some people think, well, if the back is arched, then let's face them the other way. That's not going to stop the arching. So the reason why the arching is there is because we have a herniated brain. So there was a question on the table about anticonvulsives. Is this a seizure? That's my question to you. Is this a seizure? No. So once the brain herniates, then we need to be looking at how to correct the herniation component. So I did kind of tell you guys that I would show you what a herniated brain looked like. I didn't kind of tell you, I said that I would. So let's look at a CT, a brain CT, so you understand kind of, you know, uh, what that would look like if you saw it on CT. So say for instance, you were looking at an image of the brain. So I'll share my screen again. And you can look these up just as well, but just kind of to bring the point home. So all of these are examples of cerebral herniation. First and foremost, let's just look at a normal brain. Let's look at a, normal. We'll do that. So that way you can see what the difference is and why this is so significant. It's turning. All right, so in a normal brain, and we'll just pick, this first one here. In a normal brain, you can see the ventricles that are present. So here's an actual comparison with somebody that's actually having, issues with the ventricles. You should see this butterfly shape when you're doing the CT slices, right? You should see the midline here. And, you should actually see some of the brain tissue definition. So here's, it's not all straight, but you definitely see the brain tissue. And it should be curvy and kind of twisty looking. So this would be something that's normal. Now let's go back to the person that may have a herniated brain. And then you'll see the difference in what we were talking about. So the first thing would be to see if you could see that butterfly shape on CT, on those CT slices. So we'll pick one here. So looking at this brain, can you see the midline suture? So you see it here, but it's actually slanting, has a downward slant to the left. And then here, you lose it in here where you should see the ventricles. You don't see that butterfly shape that you normally would. You actually see a small piece of the ventricle here, and then here's the suture line. And this here kind of, it doesn't even look straight. It looks, oblong or misshapen, okay? So there's different types of brain herniations depending on the severity, etc. But the key thing, you do want to see that butterfly shape of the ventricles, third and fourth ventricles in the brain. You do want to see that. And when you don't, then, there's definitely an issue that's going on. Whether you need to know what type of herniation this is not relevant. Just more so you understand that there's definitely a problem, because as that cerebral edema continues, it starts to, swell and encroach on other tissues and also encroach on the ventricles themselves. So that's why you have those issues. All right. Does that make sense when we're talking about herniation and what that is? So for clarity purposes, your earliest sign that there is an issue with the brain would be the patient's mental status will be changed. So it'll decrease from whatever it was. To look at brain functionality to let you know where this injury is, that would be your pupillary test. So let's look at seizures. Seizures is another word. What is the other word for seizures? Epilepsy. That is the other word for seizures. So when you're there's different types of seizures. So now I'm going to switch now to my whiteboard so that way we can talk about these different types. And then I'll share the whiteboard screen. Hide that. So, what's really happening in a seizure? Or why do folks have a seizure? What's happening internally? So, there would be some type of abnormal firing, right? Okay. I'm reopening the chat so I can see your responses. There we go. All right. So, we have some neuronal excitability. And, this could be from so many causes: head injury, drugs, alcohol, um, low sodium levels, arsenic poisoning, a brain tumor, the eclampsia. So all of those are, those are some common symptoms. So just in kind of a recap. So, decreased glucose, so hypoglycemia, decreased blood sugar. These are all causes of seizures. Remember eclampsia? So we have preeclampsia and eclampsia. So we talked about those prior. They could have alcohol withdrawal. I'm just going to say ETOH, withdrawal. We also have head trauma. Low sodium, so hyponatremia can be a cause. Abscess in the brain. Those, it's not a tumor, but it's a brain abscess. And we won't leave out brain tumor. So those are just some of the causes. There's an extensive list of, how seizures can develop. What would be a rationale for them? I mean, even a stroke. So, depending on where that stroke is and how it impacts the body, this could also be a cause for the individual developing, seizures. So we have the neurons that become super excited. And what may be missing from that? So if we may have the excitatory neurons that are stimulated, right? Let me add in fever real quick, because that's a special kind that's seen in your pediatric patients. So thank you for that, Dinell. So it's all on how the neurons, handle information. So when the neurons are stimulated, it causes a response. So things get excited, or, it makes something happen. And then to make a response happen, you must be able to release, what is that neurotransmitter, that glutamate? And then we also have an inhibitory neuron, because everything it's like a yin and a yang. You have something that works, but you also have another element to keep it in check so things don't get out of whack. So now when you inhibit or have an inhibitory neuron, then that's going to stop something from happening. So in order to prevent something from being overstimulated or losing its going out of whack, for lack of a better word, then it would release the GABA neurotransmitter. So there's usually a balance between your excitatory and your inhibitory neurons. If for some reason those inhibitory neurons become damaged or dysfunctional or injured, then this is going to now cause the excitatory neurons to take over and have more control. And so it'll begin to stimulate parts of the brain, sending all of these abnormal signals, hence having a seizure. So you have to have a balance. I'm just going to change pen colors here. You need to have a balance between the excitatory and inhibitory neurons. So the excitatory has glutamate as its neurotransmitter. I'm just going to put NT, but this is neurotransmitter. And so your inhibitory has GABA as its neurotransmitter. So the issue becomes when there is a dysfunction here, damage or injury, then this one here will increase in excitability. Hang on just 1 second. All right, so there was a question here. Yes, that is true. Because if there would be an imbalance, you would be missing, that's a very good question, Jessica. You would be missing the GABA, or you would have less of it available. Does that make sense? Okay. So once you find your culprit, then you know actually how to fix it. And that's usually the big issue with seizures and trying to figure out the best way to manage them, etc. So there's different, as I said, different types of seizures that an individual can have. So they last between 30 seconds and 2 minutes. This is kind of normal. So their duration. If you have a seizure that is greater than 5 minutes, is that good? Absolutely not. This seizure now would be considered a medical emergency. Because this is probably what? There you go. Status epilepticus. You just take the L out of the first, right after the E, Tom. Yep, so status epilepticus. So that is what you don't want to see happen, okay? So you can have a focal seizure, you can have a generalized seizure. Sometimes they're not really sure why the person has the seizure. It usually does not affect the person's intelligence, so that's usually not an issue. But they do have the International League Against Epilepsy, they classify the different types of seizures. So let's clear the board and then we'll talk about what is a focal versus a generalized seizure. So let's start with focal. So tell me about focal seizures and, how do they work? Because those are usually the most common types of seizures. When you say focal, is that going to be throughout? Exactly. Focal means one area that it's localized to. So basically, one area meaning one hemisphere. Okay. Can this go to both hemispheres? Can a focal seizure become generalized? Yes. So that would be the thing you would be monitoring for, and it would be based off the signs and symptoms. So then they break it down to having a focal onset. My fan is like blowing stuff. A focal onset. And this would be awareness. So they would be aware. Okay, this used to be the partial simple seizure. And then they also have, I'm just going to make a little line here as a comparison. The focal onset. And now this person would have an impaired awareness. So these are the two types of focals. So you have either they're aware or their awareness is impaired. Okay. And this is, prior, this was known as the complex partial seizure. Okay. So just to kind of bring the names back into focus. So they're as you can see, they're changing the names from whether they're partial to complex to now being, focal versus, impaired awareness versus not aware or having awareness. So usually, as we said, one area of the brain can be affected. Signs and symptoms will vary depending on which one you have. So in your focal awareness, it usually begins locally, as we've already said. So usually our onset is a local onset. However, it doesn't generally cause a change in mental status. Okay, so there's usually no alteration in mental status. So I'm just going to say AMS. They usually present with sensory deficits or sensory symptoms. So, flashing lights. They could have unusual smells, auditory hallucination. Can be things that are distributed. They can have a presentation where they feel like they're dreaming, or they could be angry, or they can be fearful. This is usually precipitated by an aura, so they have a positive aura. But again, it lasts for a few seconds, and it's usually there's not a trigger, but you could have sensory and motor involvement. So there's usually not a trigger. So no trigger factor, but it can involve both sensory and motor. When comparing that to the impaired awareness, so this person definitely isn't aware, hence the word. They can have an alteration in mental status, so AMS is positive. They can have amnesia. That's possible. Then this is going to be amnesia of the event. They could have hallucinations. And if they do have an aura, they can have a positive aura. I forgot my star. So positive aura. Or that feeling of deja vu. During the seizure, depending on where it is, the patient may or may not be able to follow simple commands, but this is going to last 1 to 3 minutes. This seizure is primarily in the temporal lobe. Is where you see most of those. They can also have something called automatisms. What are automatisms? So this is where they actually have movements or activities that automatically, that they're doing. So this could give me an example of automatisms. Okay, repetitive, non-purposeful movements, awesome. So lip smacking, they could be rubbing their hands together. They could actually be pulling on their shirt at the same location just repeatedly. So those would be things to let you know, okay, this is oddball. Lip smacking is definitely a more common one, but hand rubbing, kind of like when you use hand sanitizer, or grabbing on their clothing, grabbing something repeatedly. That would be an example of automatisms. So I'll just put that out there. So the lip smacking, hand rubbing, and just basically rubbing the hands together. And the last one would be grabbing, grabbing clothing or something repetitively. So that's focal. So those were your previously known as the partial seizures. All right, so then when we get to the generalized seizures, so now we'll talk about the generalized. In the generalized seizures, now we have the grand mal, the petit mal, or absent seizures, tonic-clonic, those are, or atonic. But usually the generalized means that it's going to impact which part of the brain. So would both hemispheres be involved? Yes. So we have both hemispheres. So basically the entire brain. All right, so let's talk about petit mal seizures or absent. Let me call it what it should be, because right now I think your book calls it absent seizures. So let's just go there. So we have absent seizures. What is that? Who can describe for me vocally what an absence seizure would look like?
Isn't that when they stare off into space like they're daydreaming and they don't move?
So it could be like a kiddo, running across the playground, and then all of a sudden the kiddo just stops and freezes in place. And from an outside person, it'll look like they just, paused and started daydreaming. But in truth, this is an absent seizure. And then whatever the next movement was due to be next, they continue it. So it's like their brain freezes for a minute, they freeze, and then the next neuron synapses to the next piece of what was supposed to happen in the first place. Does that make sense? So they could be running, they could be playing, and whatever the next movement would have been normally, they make that next move. So absent seizures have been confused a lot with daydreaming because of that person has that gaze that they stare off into space. And, so your teacher may have said, hey, stop daydreaming and get this work done. So it is more commonly seen in children than adults. but they have a brief change in consciousness indicated by the fact they could be blinking or eye rolling or something like that, or a blank stare, which is normally the one that they get accused of. So the hallmark sign to an absent seizure is the blank stare, although there may be some others, but the common thing is just like I described. Okay. Usually lasts between 1 and 10 seconds, and they can, have this happen, up to at least 100 times a day, if not more, if it's not treated appropriately. So this would be considered a non-convulsive seizure because there's no additional rigidity, muscle relaxation, and contraction that's going on. But they have a very uh, diminished post-ictal stage. So that would mean after the seizure. So usually, post-ictal could be from 30 seconds to, several minutes. This person will, as I said, go back to doing exactly what they were doing or would have done in the next movement. So that actual post-ictal phase is almost negligible. It's almost like non-existent. Our next type of seizure is the tonic-clonic. Now, I will say this, you can actually have, just clonic seizures without the tonic component, but we're not going to get into that. We'll just talk about some of the more common ones. But our tonic-clonic, this was the old grand mal seizure. So this is the one that people try to emulate, when they don't want to get arrested for jail, but they look like they dancing. Yeah. So the person can have an aura, so that, that's a possibility that they may have an aura. They can have a loud cry as the seizure is getting ready to go into fruition. And the interesting thing about auras can actually be giving you a heads up that the seizure is going to be happening. And it could be up to a day worth of notice that the person may have, depending on what their specific aura may be. The patient will have positive loss of consciousness, so positive LOC. And here's the issue with grand mal seizures. If the patient is in the bed or on the sofa and they stay on the sofa or in the bed, do we need to worry about any safety concerns like head injury, neck injury, broken wrist, lacerated tongue, if they're in the bed and stay in the bed? There's a couple things we need to worry about, but we don't need to necessarily worry about, them falling and hitting their head. Because if they're from a standing position, then we are talking about anything can happen to this individual. So, if they're having the seizure while walking or standing, then this is going to be more complicated than someone that was actually having a seizure in their bed. Now, make no mistake, people have died in their sleep from seizures. Matter of fact, one of my good friends, this happened about 4 years ago. So just, you have to know what you can and cannot do and make sure you're following instructions outlined by your physician. But here in this particular instance, the body's going to get stiff. So we're going to have, rigidity. And someone asked me to describe an aura. So the body is stiff. And I'll get to that, but let me finish this first. So this is known as the tonic phase. Okay. Then it's going to alternate between muscle spasms. So we're going to have positive muscle spasms and relaxation. This is your clonic phase. So the body gets tight and stiff, and then the muscles contract and relax and contract and relax and contract and relax. There's a multitude of things that can happen during this time frame. Number one, we could end up with a lacerated tongue, lacerated mouth. The person can bite their tongue. So we would be looking at, lacerations there, bleeding, airway obstruction. The reason why you don't put your finger or anything in their mouth is because if you do, then they may potentially clamp down so tight that they take your finger or a digit with them. They will also could be incontinent. Oops. Of bowel and or bladder. They'll have dyspnea or labored respirations, or they can have apnea. Okay. So usually this seizure lasts about 2 to 5 minutes, 2 to 5 minutes. Let me just say in duration. But when they regain consciousness, they may be totally confused. They may come up very aggressively, have aggressive behavior. They may have a headache. They may have, you know, they just may be relaxed. We don't know how the person's going to wake up from the seizure. Okay. So after the seizure, this is known as the post-ictal phase. Ictal means seizure, post means after. So the post-ictal phase, the patient now may be in a deep sleep. They may, stay relaxed because of all of that activity, excitability. Their body has to recover. Okay. So if your patient is having that seizure greater than 5 minutes and it's a hospitalized patient, then who we're going to call RRT. Okay. So the question was about the auras. So what would be the best way to explain an aura? An aura is basically a precursor or an identifier that lets you know it's the patient's trigger that, hey, this seizure is getting ready to go down. So sometimes they have a certain smell. It could be stress, but it is usually in the patients that have a focal or a tonic-clonic seizure, and it happens at the very beginning of the seizure. It's a warning sign that the bigger seizure is about to go down. So they may get a weird taste in their mouth. They may feel dizzy. They may not be able to speak. They may have, sudden dread or sudden anxiety. They may hear things. They may see things, but it's a warning sign. Okay. So part of that history, yes, but with the TIA, you really don't, your warning sign is that, you still have the signs and symptoms of a stroke. However, it's letting you know if you don't change things, then you're going to have a stroke. So this is a little bit different of a warning sign because there's no, I feel weird before you get the TIA. It's like if you're going to get the TIA, it's just going to happen. Does that make sense, Jessica? Where this one is saying that, you may have your aura may be, you see flashing lights. And then that's your aura that, okay, this seizure is about to happen. So it's different for each person. So no one has the same aura. No one has it the same way that the person before had it. But the key is to find, what triggers the process and then what do you experience before. So these would be questions in the history that you would have to ask. So before the seizure, did you feel differently? Did you have a headache? Was there anything abnormal about yourself that you noticed that happened? Or each time you've had a seizure, has there been one thing that's been constant prior to the seizure? So it'd be something to assess because you want to know, hey, do they have an aura? Because now, we can try to figure out how to work through that. So, before the aura happens, there's actually a period or stage, that may precipitate before that piece, like depression or anger. And that may start days before the seizure actually happens. So it's trying to get them to trigger into, hey, what things are going to precipitate the seizure or give you a clue that this may be going on. The post-ictal, hey, everything's already gone down. But again, we're going to protect the environment. We're going to lower the bed, and protect the environment means pad those side rails, take any equipment that could be injurious to the patient, away. Put on a non-rebreather if you can to try to provide some oxygen. Make sure the airway is, can you suction the airway? Only the sides. So don't try to pry any teeth apart. Don't do anything like that. So if you're, start seeing blood, then you want to try to eliminate that as much as possible. Don't let that stay around, floating around, and the person aspirates on it. From a post-ictal standpoint, where the brain's recovering, then, it may, that may take the tonic-clonic portion hours to days to resolve. But they're very tired, they're very sleepy, they may be confused, they could complain of a headache, and then any injuries that they sustained during the seizure, those are the things that you're going to assess after the seizure. So, their behavior, do a neuro assessment, draw labs, and the labs we're looking for is whether the patient is therapeutic with their seizure regimen. And if it's a first initiation of the seizure, then they're going to have more studies done. Oh, wow, that's impressive. Was that her trigger? Was that when she would have a seizure before, would the dog barking be a part of that?
I guess it was. It was. I guess she would just hear things, necessarily not dogs, but
Okay.
I didn't realize that that's what it was her aura at the time, because I didn't really know much about
seizures.
seizures.
And, seizures are really, it's a complicated thing because, my mother-in-law suffers from seizures, and my godmother did too. And both, we have two different folks, which really is interesting. My godmother was like, I'm not taking the medication, and she didn't. And there would be days that she would have a seizure and be out for days. You'd literally be calling her. And then, we'd have to call another family member to, check on her. And so, with my mother-in-law, she was very regimented in making sure that, hey, I have to take this medication at 10 o'clock every day. And they do, because that therapeutic window is paramount that they stay above, and they can't be non-therapeutic. So that means that if their levels are less, then that seizure activity is more prone to happen. So they may get an EEG afterwards, to assess brain activity. It's not, painful or anything like that. Things that can trigger a seizure, as I said before: stress, trauma, overexertion. Ladies, if you suffer from seizure, it can just be that time of the month. So your menstrual cycle, pregnancy, ovulation, all of those are potentials. Electrolyte imbalances, especially hypoglycemia, dehydration, certain smells, certain strobe lights. Kiddos can have a seizure just on pre-hospital lights. So, fire truck and ambulance lights and police lights. So that it's a weird process. Recreational drugs for sure, alcoholism for sure. So, there's, it's seizure, people like, oh, yeah, seizure. No, seizure. We've had some Olympians die in their sleep because of a seizure. So it's one of those things it's talked about. We learned that it's a significant thing, but then it's like, I don't understand, there's too much brain stuff. So you kind of tap out after a while. So let's talk about some meds that we could use to treat patients. And there's a variety of meds. Some of our more common meds would be what? What would be some of our more Dilantin, Versed, Keppra, okay, valproic acid. So you have those hydantoins, the barbiturates, Valium. Your benzodiazepine is what your Valium is. And that would be for somebody that is status epilepticus. Then we want to give them like Ativan or diazepam. So we want to give them either Ativan or Valium, one of the two, preferably Ativan. But, that will stop the seizure immediately. And this is for your status epilepticus folks. Looking at the phenobarbital, so that's part of the barbiturates, so that's usually phenobarbital that they'll give them for the tonic-clonic or even for focal seizures, definitely for status epilepticus as a regimen. But what that does, those barbiturates, it stimulates GABA. So remember, in the inhibitory neuron, the neurotransmitter is GABA, so it's either deficient, correct? So this will actually stimulate those receptors and then help the GABA neurotransmitter to bring balance back into the brain. We have phenytoin, and then there's another phenytoin that's supposed to be, I think it's more patient-based, patient weight-based, or something to that nature. But again, tonic-clonic seizures, focal seizures. But here we need to make sure they're doing good mouth care and not to take any antacids or anything like milk, because it'll decrease the absorption. If you give someone benzodiazepine, you need to make sure you have the reversal agent, which is flumazenil. I got you. So that should be by the bedside. Another type would be valproic acid. That treats all the seizures. So we would be getting levels on those types of, those seizure medications, checking a phenytoin level, checking a phenobarbital level. No antacids and phenytoin. That is correct, Jessica. So those are, as I said, seizures, it's a lot, but remember, you have to have good follow-up or good follow-through. What about diet? Can diet help with seizure management? And if so, what kind of diet? Ketogenic diet. So that would be high fat, low protein, low carb. So that can also help to control seizure frequency. They could actually have part of the lesions removed from the temporal lobe. So they can actually do a surgery. So remove an area of a brain that's causing the problem, especially if it's a focal seizure, then they can take, part of the temporal lobe. They have vagal nerve stimulators to also send signals to the vagus nerve. So there's, several different types of treatments available, but the ketogenic diet is definitely one to help manage seizures better. Can your patient that has a history of seizures have something called breakthrough seizures? And then what does that actually mean if they do? So what does it mean if they have something called a breakthrough seizure?
Is it when they have like periods of being free of seizures and then another one hit?
So a breakthrough seizure could happen to a person who, although they're taking their medications, they may be compliant with their medications, but they start experiencing or having an increased prevalence of seizures happening. Does that make sense? So the whole role or goal of taking the seizure meds is not to have a seizure. So, the patient may have had a seizure, say, last week, and now 2 weeks from now, they may have another seizure. And then a week later, they have another seizure. That is not a common thing that should happen. But if it does, those seizures are known as breakthrough seizures, which means they need medication adjustments. And the medication adjustment would either be to increase the dose or what? Or increase the frequency. So they'll try not to change the regimen too much, especially if they have had success. That could add to it as well. But the first thing they're going to try and see before is if all things are on, firing on all cylinders, then they're going to look more at you know, maybe the dose that the patient is on is not therapeutic. So they're also going to now draw lab work. Which lab work? Seizure medication. Yes. So they're going to draw lab work on the seizure medication. So if they're on Keppra, if they're on valproic acid, if they're on Dilantin, phenytoin, you know, phenobarbital, they're going to draw those levels to see, is it therapeutic? And you guys understand about the therapeutic window and, you know, lethal dose and, you know, minimal dose, but it's less than the minimum dose. You guys got that, right? And if not, I don't mind bringing that up. But that would be for any medication. So even if it was, you know, for your statins, you still have to have a therapeutic window. All right, so just briefly, all right, so here, when you're talking about medications, just, you know, just for clarity, so that, you know, that way you guys understand, you have, it's a graph. So we'll say this will be your therapeutic range, right? And then, so here is the therapeutic range. So if they're going to draw the blood levels, they want it to be in here and in here. So once you get out here, now this would be toxicity. Up here, this is a lethal dose, okay? Down here, this is non-therapeutic. And so basically what this is saying is if this is my minimum level here, let me just change colors to, yeah, this will work. So if this is my minimal level and this is my max, then even at my my most extended point, my medication should be here at the around the minimal level, but above. Does that make sense? So I shouldn't be down here. If I'm down here, then I am not therapeutic. I'm not medicated appropriately. Which means if I'm here, then I'm going to have seizures or I'm going to have decreased effectiveness of the medication. You can look at it as being subtherapeutic. Yeah. So you may see, you know, peaks and troughs. So a peak is, you know, where is the level when the medication is at its peak stage? Is the patient still therapeutic? And a trough is where is it? Where is the medication level when it's at its lowest point? So you may draw peak and trough levels like on vancomycin and gentamicin and things like that. So you will see that in clinical. But this is what they're looking at. Did the patient stay minimally therapeutic or where are they? But regardless, they need to be from here to here at the end of the day. Random levels check to see where they are, and they should still be therapeutic, Diana. They should still be therapeutic. So even if they just do a spot check and say, here, I'm going to check here, I'm going to do a random, and you check a peak 1 hour after the medication's given. Here, a trough, you check it minutes before administering the med. So let me just clear that up, okay? Random, you just draw whenever. So it doesn't have to be an hour after. You could check it 3-4 hours, 6 hours. You know, it depends on how often the medication's given. If it's given, you know, twice a day, so Q12 hours, and you want to check it at hour 6, that would be a random level. That would be for any level, because with some of these of what I'm talking about here are actually IV administrations. When the peak and trough, that's usually IV. But you still want therapeutic, whether it's PO, whether it's IV, it doesn't matter which route, they still must be therapeutic. Does that make sense? But since we're talking about seizure medications, they don't go home on IV seizure medications. They actually will be on PO. Does that answer your question? Okay. All right, so these are all things you would see in clinical. These are all things that if you know your patient has, seizure precautions, then you need to be checking on them more frequently, even if they appear to be okay. Because, they may get a visitor, the visitor comes in there and stresses them out, and then what? It's like bets are off. So that seizure may be, in the making. The one seizure that I didn't talk about, which is common in kiddos, they call it the drop attack. What is that seizure known as? What is the actual name of that seizure? But it's called a drop attack. Not febrile. This is an actual seizure. It's called atonic. So atonic seizures is known to be, they are known as the drop attack seizures, the legit drop atonic. So yeah, it is an actual one. So I didn't want you to be, blindsided or feel blindsided for that matter. But in this particular seizure, this is, again, I told you seizures are really strange. So here with this drop attack or with the atonic seizures, the person will lose muscle tone and just go limp and fall. So muscle tone is lost. So the patient just drops and falls. So that's why it's called the drop attack. So they go limp. So if you, on a limp, your legs are limp, that's going to be kind of hard. So again, safety, because our concern here is going to be, a closed head injury for the individual. Okay, they are not aware of the event or the surroundings. This is usually seen in younger children. This is another kiddo one, kind of like that Petit Mal is kiddos. This is for kiddos. Okay, peds. I know I have a little wonky accent. What if they're sitting? If they're sitting instead of standing, they're going to slump over. Okay. Just like the Petit Mal seizure or the absence seizure, they're going to have a very immediate post-ictal state, meaning it's going to be almost negligible. So how to prevent injuries for them? These little babies need to wear a what? Let's see if you guys can figure this one out. So just based on what I have here, yes, they need to wear a helmet. So when you see those little kiddos with those styrofoam helmets on, this is why, or one of the reasons why. It's not always the reason, but it's one of the reasons. But they do have a positive temporary loss of consciousness. So I'm just going to put positive LOC, and it's temporary. So, that's why that assessment of your patients is going to be paramount, because you want to get their history, their medications, how long do their seizures usually last? And if they had a seizure before they got to you, like say if you're an ER nurse, then you want to know, how long did the seizure last prior to, did any injuries, did they protect the environment? But those would be things that you would be, looking at. Are they compliant? So we can't always assume that they are or are not compliant, but compliance of medications are definitely going to be something that they need to pay attention to. So, if it was COVID-19 time and, money is very, getting tighter and tighter, this will make it a lot more difficult for them to, have access to the medication. So, but yeah, I wanted to talk about that febrile seizure. I won't say very simple, but here's a question for you. When you're looking at a febrile seizure and you're comparing it, or you're trying to figure out the cause, what, I'm going to go like here and do febrile. All right, so for febrile, is it because and I'm going to cheat here, is it because the temperature is high? This is my question. So is it because the temp is high? You know, we'll say 102. Or is it because of how fast or how quick the temperature rose to 102? That's the question. All right, so I have a how fast, I have both, a how fast and the temp. All right, so the truth is, the temperature itself definitely isn't good, but it really is due to the fact of how quickly the temperature rose. Our issue is with the hypothalamus. So depending on the age, remember it's immature, and having that temperature rise so quickly and not being able to do anything about it sets off a series, yes, thermal regulation sets off a series of events. So I'm not saying that the fever's great. The fever definitely isn't great, but it could have gone from 98 to 101, and just the speed of that happening is what can lend itself to the fever, to the seizure. So when you do have little kiddos that are febrile, and I think I've talked about this before, but it bears mentioning, they need to literally be stripped as much as possible. So they should be in a onesie, their little diaper. You know, we want to cool them off. Now, we don't want to freeze the kiddo. No, we don't want to do ice, because if we do that, what happens when you were cold? Just as a regular human, you start to shiver, right? Shiver increases heat production from our muscles. So that's the reason why we don't want to dump them in ice. Don't put your babies in, you know, alcoholic bath water and stuff like that. You know, those old wives' tales. You know, try not to do any of that. But, you know, tepid water's fine. It's like a little bit less than lukewarm. So it's kind of warm, but it's not that nice steamy bath. You know, things to cool the baby off. So questions about febrile seizures, atonic seizures, tonic-clonic, and just for the record, you know, the last set of seizures that we talked about, those are all generalized seizures, by the way. And just the focal with and without awareness, it is strictly focal. So all the seizures from that point on were all are all generalized types of seizures. Okay. Yes. Because remember, the body's overheating. Where's the hypothalamus? It's in the brain, and it's not on one side or the other, but it's regulating all body temp. So it's regulating your entire body temperature. Best area to get a temperature on a kiddo. It is the booty, the rectal temp. So, you know, food for thought. So when you're in clinical, someone goes, sadly, when you're in clinical and they have the thermometers and they have a blue cap and a red cap, which one's for rectal? It's the red one. Red means rectum in that instance. So, you know, don't stick the blue one in somebody's booty and then go, oh, whoa, I'm putting this in somebody's mouth. So yeah, don't do that. Yeah, red means danger zone. Okay. So does that clear things up for you with seizures? I'll send out the case study on brain tumor. So that way you'll have that to work through. The other topic we had this week was grief. And so who can tell me the Kubler-Ross's stages of grief? All right. And your book gives you several, but Kubler-Ross is kind of the one that's used the most often. And she was the one that, or her methodology is the one that is primarily used when we're talking about stages of grief. So the majority of the time, they're going to look at the Kubler-Ross model, and that would be Kubler-Ross. Her first name is Elizabeth, by the way. So if you're trying to Google her real quickly, but this is it's the Kubler-Ross model. Okay. All right. So is this model linear? Absolutely not. So we can't think of it from a linear aspect. But here there are 5 stages. And, a lot of times we find ourselves in this stage quite a bit, including myself, just be in denial. That's the very first stage. Then the next stage is anger. Then we have bargaining. Then we have acceptance. Or is it depression? Should be depression first.
Depression first, yes, ma'am.
Yep, then acceptance. Okay. So here's a picture to paint. You have had some struggles getting to your job. You've been warned, you've already received a verbal warning that if you're late one more time, that you're going to receive not only a written warning, but you're going to be suspended for 3 days. So you wake up, you get dressed, you're hustling it, you're getting ready to go to work, you grab your shoes, your sneakers or your tennis shoes, whatever you want to call them, your boots. You get ready to tie the shoe and the shoestring break. What's the first thing that happens? The first thing is, outside of the expletives, you're going to be like, I cannot believe the shoestring broke. The anger is they're going to literally almost be tied, but you're going to be like, mother, I cannot believe the shoestring broke. Okay. And then the next thing you're going to try to do is fix it one or two ways. You're going to try to go with that short shoestring because in the back of your mind is, I can't be late. I can't be late. I can't be late. But then you go look down at one shoe and compare it to the other shoe. And that's going to really irritate you because you're going to be like, I cannot go in with one short shoestring and another long shoestring. Your next action would be you're going to look in your closet for another pair of shoestrings that you can put in those shoes because whatever you have in there is not the appropriate ones for your job. Then you're going to be depressed because you're going to be like, these orange shoestrings are really not going to go well. Or these white shoelaces, I could use these, but the little black mark that happens with the little silver circles that you put your shoestring loops, the little shoestring loops, that's going to be irritating because now people are going to see that. Finally, you're going to just make a decision because you know you have to go. So you're either going to put pride aside and say, you know what? It is what it is. I have to get to work. I will deal with the shoestring crap later. And maybe make it to the auxiliary store sometime on your break and see if they have shoestrings that you could actually find acceptable. But you literally just broken shoestring. Same thing. Stub toe. Stub your toe. You're going to go through all of this right here. So it doesn't have to be a major illness. It's just stuff in your life. You know, you go out to your car and you have a flat tire. It's going to be the same thing. Okay. So these are those stages. And as people maneuver through those stages, and I think our concept looked at, amputation. So, it's about that self-image and what will their life be like post this process. So, someone's being told, hey, my foot has to be amputated, they're not going to like the fact that their foot, I don't know anybody that says, oh yeah, I want to be footless and legless. I haven't met a person yet. So with all of that being said, these are stages that we have to monitor for, but that depression, we really have to be careful, because if they become too depressed, then we're looking at a whole nother ball game. This could be a loss of job. This could be a change of job. This could be a loss of a loved one. But we talked about, SID, sudden infant death syndrome. What are the risk factors for that? When it happens, how does that impact the family? Okay, so when you're looking at those conditions, those are the things that you're kind of focused on. Is there grief? Is it functional? Is it like the typical thing that most people would do in a process when they are grieving? So, are they going through those steps? And everybody's going to be at a different stage. If it was a terminal illness, the patient is already at acceptance. They've been through the denial, the anger, the bargaining, the depression. They've gone through all of that. And, whether they like it or not, is the results aren't changing. So they get to a point of, okay, this is what I'm told. This is where it is. I don't see my condition getting any better. I haven't improved in X number of days. I've seen more of a decline than an incline. Then, these are going to be pieces that they're going to experience. But the family will be someplace between they may still be at step one. And it may not be all family members, because some may be at bargaining. But just understand it's not a linear deal. And they can go from depression to bargaining back to anger. They're making these deals and saying, I would do X, Y, and Z. However, in making these deals, they're not getting the results that they were anticipating or hoping for. So that can cause them now to, become angry. And then they can go back into this, the why me? Why does this happen to me? I've done this life, I've led this life, and I've done everything that I thought I should be doing. And now I have this that I have to contend with. So, those are kind of it's very powerful to be a part of. And it's not uncommon that if you are caring for somebody and they hit some of these stages, for you to even feel grief for the individual, or for it to tap into something that you may have experienced. And now this is kind of bringing that to the surface. Makes sense? Yay, nay, maybe. Okay, so what about, how do you know people have gotten to a point of acceptance? How do you know patients, gotten there? Excuse me. Oops. So someone wants to know, how does MI fit into these concepts? Okay, very good question. So you have a person that has an MI. Now, there's so many types of myocardial infarctions, and you'll talk about that in 4th level. But from 2nd level, you did learn between angina and stable and unstable. When a person has a heart attack, that means that the heart muscle has suffered some damage. The result of that, they could end up with heart failure, and that's another sequelae that they have to deal with. So some people can move on with their life, but what if their moving on piece consists of, they're going to now be dealing with this shortness of breath and swollen feet from, heart failure, whether it's left or right heart failure. They were able to walk 5 blocks, but now they can barely walk 1 block. Does that make sense? You have a lot of lifestyle regimen changes that have to be made. Some embrace it, Some do not, because it's a change. And, if they had to have surgery after this heart attack, that's going to be another change. So my heart can tap out at any moment. I don't know if my heart's going to be able to, sustain me for 10, 20, 30 years more. That is true. So grief happens, if anytime you're going to have a decrease in your daily activities, that's going to cause a person to experience grief and loss on some point, depending on what the extension of those conditions are. So going back to amputation, people say, well, that makes sense. You lose a digit, and that is definitely a body image disturbance component. But for that individual, it's more than just the body part. I mean, it's the, what are other folks going to think of me? I'm one digit less, or I'm one leg less, or I'm now have to use a wheelchair. Now I have to change my vehicle. I can't even touch the gas pedal. I can't even ride a bicycle. Those are all going to be lifestyle changes that they now have to face. So when you're looking at a heart attack, that is the same process of how many of these am I going to have? Will I be around? Will the next one take me out the game? So we're looking at that anticipatory loss that could potentially happen. So there's a lot of grief and belly aching over heart attacks and things of that nature. So, my father-in-law had a 5-vessel bypass graft, which is a coronary artery bypass graft. And, that coronary artery bypass graft would have probably lasted him about 15 years, 15, 20 years. Massive lifestyle change. I mean, he was sad at first, like, why me? I work hard, I try to eat right, religious. He went through the whole thing. And, for him to try to change his diet, his doctor was on him about changing his diet. He had a hard time doing that. And finally, it's like the switch clicked. And he literally, when I say it clicked, he was very meticulous about whose house he would eat at. That was even amongst his own children. So, he was looking at what you were cooking and how you were making it. And if it was something, he would sit at your house and talk to you for hours, but he would not eat a drop of your food if it was not something that was supposed to be in his diet anymore. So, when I say his cabbage lasted him 10, 15 years, he had another heart attack. And when he had the heart attack, he stood up to go get his nitroglycerin pills and then fell and hit his head and had a massive bleed. So he died of an intracerebral bleed. So, that's that anticipatory process that, I'm quite sure at some point he probably thought about, because after that surgery and that first heart attack, he ended up on aspirin or some kind of coagulation modifying medication. So, you look at MI and you're like, well, they just had a heart attack. There's a lot of things you can't do post a heart attack. So stress levels, blood pressure management, if that's your issue, glucose issues, if you have diabetes, all of those things are now going to complicate that. SIDS, this is a loss of a person that you carried and cared for. If you're the guy. For the mother, it's definitely a loss all the way around. That they create, that they were very instrumental in creating. So not knowing the causes, or looking at maybe prior history that could have led up to this point, those things are things that really can break a marriage under those particular situations, because folks start blaming the other individual. Well, maybe earlier in your life, had you thought about how this can impact yourself later, instead of just being self-absorbed, and then it just continues. Terminal illness. So any terminal illness, dementia, for example, think about that grief and that loss. So, and there's different types of dementia. If you weren't aware of it, there's a vascular dementia And that vascular dementia is related to like coronary artery disease and diabetes. So just think, we talk about coronary artery disease being modifiable. So if that person has vascular dementia, then of course, that person's going to be looking at, maybe I shouldn't, I should change my dietary regimen and have less, less fats in my diet and more fruits and more vegetables. Does that make sense? Regret. So, when this last piece, which is kind of a wonky way to end this semester, is to talk about, grief and death and dying and loss and all of that. When we started the semester talking about, life and birth and so forth and so on. But, your patients have so many things that they are grappling with, that we just have to, be aware that whether it's an adult or a pediatric patient or an elderly person, these things, this is a part of the life process. You could still do everything right and end up with something that's terminal, and you will be asking yourself, how did this happen to me? So you're going to still go through the Kubler-Ross stages, and your family's going to be someplace else in the process. So, with the terminal illness, it's a long-term disruptive. It's a disruption to the household flow, because now we have to look at, nurses coming in, assisting, medications. Your routine is not necessarily the same. And if it's a pediatric patient, they may not even fully understand the concept of what they're going through. That this could actually lead to death. They can't grapple over that process. Their behavior may become, they may regress to an earlier stage. When you're looking at pediatric patients, the parents will be in different stages of grieving. They're not going to be on the same page. There's going to be strife there. So, this is going to have long-term effects on the family after they're gone. So they're looking at, how will my parents cope? You'd be amazed some of the things that kiddos focus on in the midst of their own tragedy. So just, so as you're going through those are the points, how do we recognize that this is an issue? What things can we do? So when we did the Q&A last Saturday, and we had that question about the guy who was he was going through some grief, had lost his wife. He was kind of sad. And then we talked about what types of things we could do to help promote, improve his activity and mood and so forth and so on. And it was more so, let's get him out amongst people. Let's minimize self-isolation, because that is not a good thing for patients to be isolating themselves. So, because that will now lead to depression, and then that continues on. But support groups, I think that was one of the questions or the answer choices that was a part of that scenario. Ask them to verbalize their feelings. And unless you have gone through the exact same thing of what they've gone through, don't say, I understand what you're going through. Better words would be, what, I cannot imagine how, or I could only imagine how stressful or how painful this must be. Something like that would be more appropriate. Kind of help them find some strengths and things that they can do up until they can't do them anymore. So some folks will want to continue to do their daily routine up until they can't anymore. And there's nothing wrong with that, but just making sure their environment's safe. You'd have to do a lot of active listening. So that means a lot less talking. Don't forget about medication administration is needed, counseling support. They're having their clergy come over, to visit and things of that nature to kind of keep the person at least in a positive frame of mind. At some point, all of those things will, they're going to transition to the next level, and then their body's going to transition to the next stage. So does that make sense? Okay. Wednesday, we have our last lecture, which is on end of life. So things to think about with end of life is like, palliative care, what that entails. We're not really improving the patient's life. It's not, when I say improving, they're not going to now have a reversal of their condition, but we're looking at the improving the quality for how they choose to die or how they're going to die. So we're still allowing them to make those decisions and those choices, and getting some, having some of those more difficult conversations, like the living will and advanced directives, and so that way the rest of the folks know how to maneuver. And you'll see a lot of family dynamics and things related to that. So we'll talk about those concepts this coming Wednesday to kind of ground us on the process. And if you're an ER nurse, or even if you're not an ER nurse and you're working at the nursing home and your patient dies, what are our roles and responsibilities, to that process? Who calls the organ transplantation team? Who looks at patients' belongings? Who's responsible for, getting the body prepared and calling the appropriate folks? Do you need to call the medical examiner? What are the things that we as nurses need to do? There's some things that we do that should be really, that really belong to other folks. But, we're going to talk about those pieces and, where they are in that grieving stage, and what other types of grief, because there's an uncomplicated and then there's a complicated form of grief, and that the uncomplicated just is more of your sadness and your anger, more of the Kubler's area. Your complicated is more, they're like laser focused on the individual. They just cannot move on to any stage. Depression, suicidal thoughts, that would be more of the uncomplicated. That'll be more of the complicated process. What was that, Louina? Which part happened to you?
Having a patient die on me.
If you have never experienced that, the first time that happens to you, I'm going to tell you, when it happened to me, this was I had the strangest nursing career. I kicked off my nursing career really, really weird. But my first day in it's now called the CVT ICU, the cardiovascular thoracic ICU at Parkland. But before it was just the CCU, the critical care unit, a coronary care unit. And my first day as a new ADN nurse, I had a 25-year-old young lady who was in adult respiratory distress syndrome. And, I heard about it and I was like, oh my gosh, that day they were putting in the 7th chest tube. And I stood in the doorway and I looked at this little thin, limp body with the 7th chest tube about to be placed to try to save her life. What she had done is gotten into an argument with her dad. And she said, I will show you. And she grabbed a bunch of his blood pressure medications and she swallowed them. So, lo and behold, a toxic dose of a medication that your body does not need, that process ensued. And she died the next day. So day 2, brand spanking new nurse. And actually, I wasn't even an RN yet. I was a graduate nurse. I did not take my write for my boards until I think it was July. So this happened. I started June 1st and I was writing for my boards in July. And this was crazy. I had never experienced anything like that. I was just like, this is just bizarre. But now it didn't matter what I had experienced. I mean, now I'm sitting here, all the aftercare and all of that. And that was extremely stressful. Or patients being admitted to the unit that same year, but just that was in December. It was Christmas Eve, and a African-American woman came in and she watched her feet swell all day. She was making a bunch of food for somebody she would never say. But by the time she got to the hospital, the heart attack she had was so huge that they told her she would not make it to see the next day. And she didn't. 5:30 that morning, she went into complete cardiac arrest. And we had nobody to call. I said, well, you were cooking food for somebody. Do you want us to call those, call those individuals, even if it was a neighbor? She said, no, I don't want anybody here. So yes, those things are, they're due to come. They're bound to happen. So hopefully kind of walking, going through this, you guys can, understand that this is going to be a part of the job. And I'll be the first one to tell people I am the biggest chicken crap of all time when it comes to dead people. I do not like taking people to the morgue. Never have. I don't think I ever will. And you're like, are you serious? And this has happened. And I'm going to tell you why. When I was a school age kid, my mom had been admitted to the hospital for anaphylaxis. And we thought she was going to die. Well, my brothers, I have two older brothers, they were supposed to be taking me to the cafeteria to get something to eat. They took me to the morgue. They didn't take me to the cafeteria. And so I literally was screaming bloody murder all through that hospital. And when I finally found my way out of that area, of course, my brothers were tickled pink. By the time I got back to my dad's, went to my mom's room, my dad was like, what the heck is going on? And when I told him, oh, of course, my brothers were in big trouble. But since that point, it's like morgues and me do not agree. So if I ever had to take a patient to the morgue, I would literally open the morgue door, give a gentle push of the stretcher and pray it didn't hit any other stretcher that was in there and close the door and then run. So even people that took them down there with me, I was like, okay, you go ahead, you go in, I'm not going in. So if I have to do all the body work, I don't care about that part. It's the going to the morgue part. So I'll do all that other stuff. It's just that piece. It just gives me the heebie-jeebies. So Dianelle, you said you've done plenty of life withdrawal patients. Yeah, you get to a point, then you become almost desensitized, because it happens so often. You're like, oh my gosh, do I not care about people anymore? You don't really lose compassion. It's just more of, this is just a part of it. But, those belongings and things like that, you do provide that therapeutic touch to to support, family and the patient. You call the organ transplant coordinator, and then you're going to take the patient to their family to go see the patient, to view the body and stuff like that. That was kind of our responsibility. But the one thing we're not really responsible for the clothes, though. A lot of people feel we're responsible for the clothes. Usually there is somebody else that takes care of that, like, the chaplain. They kind of work a little bit closer to the family with the belongings. We do put them in the family bag, but we don't necessarily, make sure what their disposition is with the funeral home. So I got to see an old Morgan Terrell. Okay, I was on tour with a group. Okay. And stopped and read the procedures posted on the wall. Then they turned, stop. See, I would have just lost my holy mind. Especially when you have a room full of people and they're still, oh my gosh, yes. And there's a hair, oh my gosh, yes. I can believe that. Yes. So you guys, if you're already out there, you understand. If you've never experienced it, it's not to terrify you. It's just, I can't tell you how you're going to react. I just know how I felt. And will you cry for some of your patients? Absolutely. And it is absolutely nothing wrong with it, but just make sure you don't cry louder than the family members because that's going to look a little bit weird. So I'm not saying that you're not going to cry, because trust and believe you're going to get attached to some patient for whatever reason. But then the family invite you to that. Sometimes they do, but you got to, try to maintain your professionalism at all times. Just, it's not to say you can't have outside relationships with folks, but you will develop compassion for people. It'll be the person you least expect to bond with. And then all of a sudden it's like, for some reason that you're going to be drawn to that individual. So on a lighter note, let's, if you have any other questions, I will send out the brain tumor. We can talk about, some of the, we kind of covered a little bit, but we can talk about, I'll let you do this and we'll work on it, talk about it on Wednesday, but then we're going to finish up with this end of life and move on to transitioning, getting ready for the end of the semester. Sounds good? Where do we submit our APA papers? Miss You should submit it under your clinical portal is what I thought it belonged to. I will double check that for you, Ms. Rodolphe. Send me an email to remind me to check it because I don't want to forget that. Okay. So I appreciate you guys giving up part of your Saturday and then listening to me literally almost hack through this lecture. I actually text my daughter. I was like, can you give me some water, please? So, all right. So try to enjoy today, and then we will see you all on Wednesday.
Go
ahead.
So there was a PowerPoint that you sent out for clinical with the TBI. My clinical group has not finished it, and I don't know if we will finish it in time. So I was wondering if maybe we could.
You'll finish it. So the group that did not have clinical on Friday, you're going to finish the PowerPoint next week. Is that the group is that what you're speaking about?
No, we had clinical on Thursday with Miss Jolly.
So you did you do it the week before?
Yeah, we've done it 2 weeks now, back to back.
What do you know? Send me an email and tell me what slide you're on.
Okay.
All right.
Okay. Thank you.
Okay. See you guys.